deal with a problem here that we think you will very rarely get, especially, as we say, these babies that want to come early at home. So we're dealing again with an unusual birth. We do consider it an emergency, but mainly because there is a prompt. You know PROMPT, the obstetric book of how to deal with emergencies. We follow PROMPT, P-R-O-M-P-T. And we follow the sort of algorithm in that. And this is for when a baby, if you get called to a birth at home, and you remember we were telling you, you encourage mum to get the head out, maybe to do some blowing when the head is visible and you can see it crowning, so that she's sort of a bit easy on her perineum, so the baby comes slowly. With this birth, you might find the head is coming quite slowly anyway, as a matter of course. And there's a word that we use that you need to bear in mind. It's called turtling or turtlenecking. You know what tortoises and turtles do, and you know what a turtleneck is, like jumper. So it's where the head comes a bit, and we would expect a head to come a bit and go back. That's normal. But it's when the head is kind of out, but maybe not quite out. The chin is still stuck. We will try and show you. Now, you may need to move because we don't really want to have the legs up at this stage. So,
she's nice and slimy, that way.
Yes, we put too much lube on actually. So,
chucking.
The head restitutes, and you may find there's still some of the perineum covering the chin, and it's not properly out, but it's bobbing in and out.
And it's really tight against the perineum.
This
literally really tight.
Like, it's almost like it's trying to get back.
Yeah. What you've got. What you've got is the pelvis like this. Okay, here's the symphysis pubis, the pubic bone. Here's your sacrum and coccyx down there, and the baby's got to this stage. But look what's happening with the shoulder. Can you see? It's impacted on this pubic bone. So whatever you did, if you pulled, it would make no difference at all. It's what we call a bony problem. The bone of the shoulder is stuck, impacted against the bone of the pubic bone, of the, symphysis pubis, the pubic bone. Okay, so that's what you're seeing. I hope you can see that at home. Okay. Now in this case, we can see the baby is facing towards Daisy here. So that is important to note, which way we think the baby is facing. So it's the other way. So this is probably this way. Yeah. So the woman's having contractions, and the turtling is going on and on. Nothing is happening. Remember, at this stage, a normal birth, with the next contraction, the baby would probably be born. So you diagnose the problem. What is the problem? Shoulder dystocia.
Question in the chat.
Yes?
So the question is this: when they are in the sac and they have shoulder dystocia, is it better to leave the sac intact or burst before?
Yeah, leave it. No, we don't.
You wouldn't interfere with it.
So leave them in the sac and deliver it.
The truth of the matter is, if it was in the sac, it probably wouldn't happen. This is going to be after the waters, because the head's out.
Okay.
So the membranes have been burst already.
An on-call baby is very, very rare. Where a baby's still in its sac.
You think when it's in the sac, it's all quite slow.
We have had students. We had one last week delivered one in the sac.
Yeah,
they do get them.
It does happen, but it's rare to get shoulder dystocia with one in the membranes, I'd say.
Excellent, thank you.
Okay. So at this point, you've had a couple of contractions with turtling. You've diagnosed your shoulder dystocia. The first thing to do is get the woman onto a hard surface, either the floor or the bed. Get a helper. I'm going to be the helper because you're delivering, aren't you? And we'll go 1, 2, 3 and legs up. Okay, ready? 1, 2, 3, up. And you try and get literally knees to nipples. You don't need to say that to her, but that's what you're trying to do. Okay? It's not legs out here. You want them as close to as possible to the body. And the whole reason for doing that is, of course I'm the one without the reason for doing that is to try and maximise the space in the pelvis and hope that the baby will drop down.
Please do as well note when the head comes out, because then you will know how long you've waited for this shoulder.
Also, it's a good opportunity to explain to the mum, I'm just having a little difficulty delivering your baby's shoulders, okay? Just to say, you're not putting them into a panic, but obviously you are going to be doing some manoeuvres that wouldn't normally be done in a normal delivery. So you do need to tell them what you're doing. I need you to get your legs so your knees are up against your chest, okay? And this will give the baby more room to be delivered.
And with this one, we don't really encourage them to push, because it can create more problems and more injuries to the
Because it
shoulder.
just impacts the shoulder more against the bone.
And I think, isn't it, it's a very high
Yes, about
percentage,
80%.
about 80%, just by putting the lady into McRobert's position will actually allow for the baby to be delivered. That one manoeuvre is about 80% effective.
Okay, so we're going to try, and we at the same time, do you remember we talked about axial traction, where you're following the line of the spine? So Sean is going to try and deliver this baby in McRoberts by axial traction. And she can tell very soon whether that baby's going to come. She's not going to pull hard, gentle axial traction. Is it coming, Sean?
It's not coming.
It's not coming. We need to do the next thing. Now, this baby is facing that way, so we suspect that it's lying like this inside. I'm going to try and push that shoulder over to get below the pubic bone. So I do sort of CPR hands, and I'm going to go like this and push. You can either push like that, or you can try a rocking push like this. Whichever works, we ain't fussed. Is it coming, Sean?
No, it's not coming.
Poor little baby, what can we do? At this point, you can think about going in to the baby and look at the pelvis. That's how it is. You're going to aim for these gaps here. Not here, not there, because you've got a sacrum, but in through here. Can you show the camera your hand? Sorry.
You might need to drop it down so they can see.
It's actually called Pringle hand. So imagine that you're actually going into a Pringle tube and getting out a Pringle. It is actually in the prompt manual as Pringle hands. That is actually a term. So you've just got to remember that. And you're going in to the sacral hollow.
This is the best place to go. And you're basically going to try and get some pressure behind the shoulder. We call this the anterior shoulder because it's on mum's front. So it's the anterior. You're going to try and push like a corkscrew to twist that baby so that it will come out. Do you think you can try it? It's not easy. I don't suppose you think of episiotomies, do you?
No.
You
Do
don't.
they do this? Would you do
We don't get
it?
to that. We're not allowed to do it.
You're not allowed to.
Surgical procedure.
Oh, you wouldn't do?
No, absolutely no.
Okay, so the next best thing to do would be to get the woman onto her all fours. Lucy, it's hard, I know, but we're gonna try and get you over. So get your legs down, come over towards me, yeah.
Okay, this is, we go.
Onto all
yeah,
fours.
we do legs up, pressure, and then all fours.
Fine, we won't do the manoeuvres, that makes it easy. So she's kneeling up, I think I'm gonna put her like this. And guess what? That will often do it as well. Because the baby has changed where the pressure is. And so, dun 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 dun, lots of lube, yeah, out it comes.
It's important to note as well, don't spend too long on each bit. We
Just
usually
keep
say about
moving.
30 seconds because if it's going to work, it will usually
Right,
work.
okay.
So, if you've tried, the fixed pressure and it's not working, after, turn the mum over, see if that will help.
So just to simplify it again, we've got Roberts, legs up, axial traction. That doesn't work. Decide where you think the shoulder is. Is it pointing that way? Follow the baby's nose. So if the baby's looking that way, we do it like this. If the baby's facing towards me, Daisy would do it your side. Again, axial traction. If that doesn't work, turn her over, help her to turn over, and try that. And if it doesn't work then, turn around and try it again. Just keep repeating.
Well, that way she's getting the adverts we're going.
Yeah,
Then we're going
you
to
might need to,
Yeah.
but I don't hold out much hope if that happens. If you've got to go in with the baby half out, half in, it's not a good picture. Any questions?
Something to also note as well, having a hemorrhage after a shoulder dystocia can be quite common as well.
And baby may very well need resuscitation.
Yeah.
So, I know.
Yeah.
Yeah.
And you may well find the baby's quite big, or you may not. A lot of shoulder dystocias are completely undiagnosed. Baby's not necessarily big, mum's not necessarily small, it just happens.
It can happen to literally anybody. There are more people that are predisposed to having a shoulder dystocia, but it could happen to literally anybody, and you won't know until that head's delivered.
Babies can get into really funny positions, but you might find just doing this might help free the shoulder.
The legs is probably what you need.
Yeah.
And again, it's not that common. We think that it's very much overdiagnosed in the hospital. People say, oh, I had a shoulder dystocia, but actually
It was just a little bit of a difficult delivery. It wasn't actually a true shoulder dystocia.
Any questions from home, guys?
No, there's nothing so far. No one in the chat. So
I think we're probably just about done.
that's fine. So what we'll do, guys online, if you've got any questions, now's the time, because we're going to stop there for you guys. So any questions?
Yeah.
I just had a question that wasn't related to shoulder dystocia. It was back to the normal birth.
Okay. Nice and loud.
You know when you're talking about hemorrhage and you deliver the placenta, so say they're bleeding quite a bit and you're a bit worried and you deliver the placenta, is that theory one way in which then the bleeding should stop?
It usually does.
Usually does, okay, and then
it will settle. Oh, that's something we can teach you, which is useful. If you're worried that a woman is having quite a bit of a bleed, especially after the placenta has been delivered, it's a good idea to try and cup your hand and rub up a contraction.
Okay.
It really can help. I've felt a uterus, which is like the stomach, a bit boggy, and if you massage it, and do it better on myself, if you do like that, then it will actually, remember, it's meant to be contracting, and that stems the bleeding.
Don't sometimes do that for pre-birth as well, to relax?
No,
No?
no, not good. Don't touch, hands off. No,
No,
no.
you can. It was really weird with my lady. If you actually just hold, when she feels contraction coming on quite early in first stages of labour, if you actually hold the stomach, you can physically feel the
Yeah,
whole
you
thing
can.
goes like a rock. Goes rock
Even if you
solid.
just put your hand on it,
She
you
just goes,
feel.
That
You're
was
like,
one of the first.
wow.
That's one of the first things as a trainee midwife that we normally get asked to do, is to feel the contractions so that we can begin to understand what a contracting uterus feels like.
just quickly go back to the postpartum hemorrhage bit, sorry. If so say the placenta is then delivered. So say the placenta is then delivered, and the bleeding then hasn't stemmed, you'd obviously then completely go emergency.
Put your
Full blown.
scintimetron in.
Yeah, and then you've got your TXA.
And would it be how soon after the placenta is delivered would you really consider that is still that's then considered to be a postpartum?
All the time that you would sort of be monitoring. You'd also be looking at signs that your woman was actually bleeding
Yeah, of
more.
course, like
So
verified signs and
she'll
stuff.
be quite woozy. She'll go white. All your usual things
Check her
for blood
HB.
loss.
Yeah.
If
Yeah.
her HB's down on 9 or something, she will be symptomatic quicker than a woman who's got an HB of 13, or do you do it in 130s now? Which
Yeah.
way we do it?
Yeah.
So like if it's 90,
Yeah, of course
she'll
we
be
do
more
want that.
symptomatic than if it's 130 and
Okay.
so on.
If the placenta's been delivered and the uterus is contracting, it would then we would then start to think it's not necessarily a tone problem. It could be something else. So it could be trauma. So it could be the fact that there's a tear that you can't see. It's obviously very vascular down there. And so if there is a tear, it could potentially bleed a lot. So that's why it's really important to manipulate the uterus, because if that is nicely contracted down, you've then got to start thinking, well, if the uterus is contracting down, there is something else going on. So you then think, it's not a tone problem. So is it a trauma problem? So that there's a tear somewhere. Is it a thrombin problem? So you
She's not clotting.
She's not clotting. So has she got a clotting disease that you weren't made aware of when she first delivered?
Or is it tissue?
Is it
there
tissue?
something left in? Have you examined your placenta? And, well, you don't have to do this, but we do. Never ever take this away, but let the midwife have it. Because we always examine, is everything there? Is there one of these little, is this like a patchwork of cotyledons? If one of these is missing, if it's inside her, she will bleed more. And she will need to go in and probably have a manual
If they're
removal.
an anticoagulant as well, would that obviously increase?
If what?
Yeah.
Yeah.
If they're on anticoagulants, yeah.
Absolutely, yeah.
Yeah. But then, you know, if that was the case, it depends at what stage you then arrive. If everything, if that's been, if the placenta's been delivered, the baby and the placenta have been delivered and everything, then hopefully, I mean, the midwives all carry TXA and you know Miso.
And ergometrin.
Ergometrin.
Symptometrin, syntosnol.
I don't think they carry Hemobate though. So.
No, I don't think we do.
Yeah. But then,
Anyway,
then
it's
you would be
sorted.
into your normal blood loss that you would deal
Yeah.
with any other
Yeah,
type
yeah.
of trauma.
Get her in, give her
you know,
oxygen,
fluids.
you know, plenty in codes,
Yeah.
and the midwife can give 2 lots of symptometrin. That should do it.
Can we give one lot?
As is one, but we can do the second one.
Okay.
after- if
No
needed.
more than 2 though.
No more than 2.
And then 2 X-rays.
Have you guys got any more questions? And we've got no more questions from the chat,